So the last of our sort of run through of fluids is really to think about, well, how much do we use, when do we use, what's our assessment for that? And the main, you will have your own practice and your own way of doing that, and so I wouldn't ever want to take over from that. But NICE have produced a really good algorithm, which is really basic and generally what we do on a daily basis, that summarises the use of an assessment, resuscitation and maintenance fluids, and you'll pick up the bits that are relevant to you guys. So in the pre-hospital emergency setting, maintenance isn't relevant, but boluses of resuscitation are, and been really key into making your determination as to whether this person needs fluid therapy, how aggressively, and what's the response most importantly to that. So as with all things, we do an ABCDE approach, and really that will pick out most of those. So there is an overarching ABCDE that we do for all patients, and within that we pick the bits out relevant to. So the ABCDE features of sepsis, the ABCDE features of dehydration, the ABCDE features of trauma, and so overarching ABCDE. But then we specifically look at certain aspects. So from us, we're looking at the assessment of vascular status, or the assessment of hydration, really. So using that airway, breathing, circulation, disability and exposure approach, that we want to assess where the person is sitting. Are they hypovolemic, so are they short of fluid? Euvolemic, so they're normal, or are they overloaded, and that's what the cause of their symptoms are. And so we take in the context of their history. So what's the pre-risk? So have they lost a lot of blood, or are they suffering from heart failure, or have they got a sepsis-like picture? What's the risk of them being overloaded? Have a look through the medicines. Are they on infinite amounts of diuretics, so furosemide, spironolactone, bumetanide, metolazone, all those standard diuretics? Have they got heart failure in the background? Have they a large ischemic history? Or actually they're normally fitting well and they've lost a lot of blood loss, or they've had diarrhea and vomiting for 4 days, and therefore their pre-risk is quite extensive. So look at the risk plus what's going on at the minute. You must take a really detailed history in order to find that out. And then you must look really at what your investigation, so your examination and your observation shows. So part of that, so your B assessment, you want to be looking at their respiratory rate is a really good marker of early unwellness. So is that raised in order to try and compensate for some reason? And have a look at their saturations, and particularly, are you getting a really good trace with the saturations? We talked earlier about oxygen carrying capability, and have a little look. What's the figure with that? Is it low when it should be higher, and are we thinking the person's just a generally unwell picture? Is there chest pathology that's causing that? And other little subtle things that maybe you don't do so regularly. Look at your pleth, that's the trace that you've got. So are you getting a good trace? Are they shut down peripherally? Are you getting a baseline waiver? So that picture where you're getting big and then small and then big and then small traces, and that's a sign of dehydration. The person's maybe not as filled as we want them to be, that baseline waiver within their oxygen pleth. Have a look at C, probably the most important within this. So really getting a bit of tactile feeling. So I want you to be feeling the person peripherally and running your hand up. Is there a fluid level? Is there a cold, warm level? So are they cold at the edges where the body's trying to sacrifice itself, and then they get a bit warmer more centrally? Have a feel of that central cap refill time. Do they have a peripheral pulse? Is that palpable? I want you to be checking their heart rate and their blood pressure, looking for those signs of shock that you know already, that horrible picture of low blood pressure, high heart rate, or is there something else going on? Assessment of fluid status also includes looking at JVP. If you don't do it regularly, really start doing it, getting the person at 45 degrees, looking over their contralateral shoulder, and then having a look for the venous pulsation, so double venous pulsation that's visible within the neck. So measuring it at 45 degrees. Is it visible? Is it markedly raised? And measuring that out, the sternal angle. Really if you don't do that frequently, look at Google, look at YouTube, measure how to measure JVP. A very raised JVP goes, this person's probably quite filled, or maybe at risk of overloading very easily. And with that comes looking at peripherally. So is there pedal edema? How far up the legs does that go? Sitting the patient forward, having a look. Is there sacral edema? So putting your hand down and really putting over your sacrum and seeing if they're pitting there. A really poor sign, a poor prognostic sign that someone who's shocked with marked signs of heart failure, really bad outcomes from those, and need to be really aggressively treated. Other little simple things that you can do. So have a look at postural hypotension. Is someone, when they stand up, their blood pressure's dropping, they're getting pre-syncopal symptoms or syncopal symptoms, and that's a sign of really impending vascular impending problems from being underfilled and requiring more fluids. Look at response to raising legs. So someone's lying flat, blood pressure low, lift the legs in the air for 40 seconds, 30 seconds, 45 seconds, and then remeasuring your observations. Did that make a difference? That's a really simple way of seeing if someone's fluid responsive. And if they are fluid responsive, then we've got scope to use more fluid to really treat that person. So adding that all together, looking at what's the person's pre-morbid risk. So when they were well, have they scope to manage a good bit of fluid? Are they risks of being dehydrated? What's wrong with them this time round? So are they losing fluid? Have they too much fluid on board? Have they cut back on their diuretics? Have they added in extra diuretics? Having a look at that. Are they septic? Are they burns? Are they DKA? Look at what the cause, know the disease pattern, and know how it responds to fluids normally. Then having a look at really what you're tactile, what you're feeling, and what your assessment of the person is, and doing all those simple things. So not just looking at a low blood pressure is a sign of shock, not just looking at a fast heart rate, but really getting feeling. Are they cool peripherally but warm centrally? Are they mottled? Have they decreased skin perfusion? And we look at cap refill times, those colours of the nipples, those little subtle features that we look at for perfusion. Are they perfusing their brain? When was the last time they peed? How much have they been peeing over the last 24 hours? Then having a look at fluid responsiveness, so swings in a pleth, having a look at fluid responsiveness by Trendelenburging the person, by looking and seeing if they've got postural symptoms. And so really you need to put all that together. It's not just a matter of going, this person is septic, therefore they need fluid. You need to know, is this person fluid responsive? And maybe using as much of an investigation, a bolus as an investigation. Someone presents to you with signs of shock, whether you think maybe that's due to sepsis. I need to know whether fluid helps this person or they have no capacity to be responding to fluid, in which case we need to be more aggressive. So if we use our algorithm and we look at the green section at the top, using our assessment must be really detailed. And so when it goes, have they an ABCDE problem? And the answer is yes. The answer is fluid resuscitation. And we know it's part of our sepsis 6, we know it's part of our Burns algorithm, we know it's part of our DKA algorithm. The treatment of fluids is pivotal and essential, and it's something that can be happening in the pre-hospital environment to assist our colleagues in hospital as well. So the answer is yes, there's green. We move on to that algorithm 2, the fluid resuscitation. It's got its own page, or you can use the overview page at the front. But initially, try and identify the cause, why is it, and what's going to predict their response. And it suggests to give a bolus of crystalloids. You can choose, again, I'm not sure what JR Calc says, but most patients of an adult disposition will be able to handle relatively large volumes of fluid, so 250 to 500 ml bolus. By bolus, I mean relatively quickly. This isn't over a couple of hours, this is a 15-minute challenge, because it is a treatment as well as an investigation. We need to know, did it help? So did the treatment of fluids make a difference? In which case I'll try and use more if I can. But if it didn't make any difference, a large, quick volume of 500 mils of fluid, I'm going to be really concerned about this person. And I'm going to be thinking, actually, do they need more than fluid? So I need to probably give them some more, but do I need to be more aggressive in terms of vasopressors, inotropes, or some other special medicine that will try and raise their blood pressure in different ways? So it says reassess, and that's what we've exactly talked about, using an ABCD approach. Does the patient still need fluid resuscitation? Fluid management isn't simple, it's really subtle, and you must be switched on in order to find this. So the answer is yes. Then you give them another bolus of fluid. If you find actually they responded but the physiology is deranged again or still deranged, give them another bolus. It says give further boluses of 250 to 500 up to a maximum of 2,000. Now probably in the pre-hospital setting we don't have this scope to try and give 2,000 mils of fluid. Probably it is a bit overreaching, but our continuum of care between the ambulance service and the emergency department is no different, and actually we add up the fluid given pre-hospital into our in-hospital calculations. If the person you've given up to 2 litres and you're not getting much difference, that's when I'm getting a bit anxious. And that comes into some of our sepsis criteria about when we start instigating vasopressors and inotropes, and do we do that early or late? And that's kind of more into the critical care aspect. If after fluid you're getting no response whatsoever, again, be anxious and really flag that up to us. That's somebody we're going to treat pretty aggressively. But we're not really going to know that until we've given really good volumes and reassessed. So at that stage, we've finished our resuscitation. I'm not going to talk too much about replacement and routine maintenance of fluid. We touched on it earlier on, but it's there for your information that some people need up to 25 to 30 mils per kilo per day, with a bit of potassium added into that, with a bit of glucose added into that, to maintain that homeostasis intracellularly, extracellularly, and then let the kidneys deal with the rest. And where possible, get people drinking. So if someone's got a bit of sepsis and they can handle oral fluids, that's counted into it. Your DK that's not persistently vomiting, give them sips of fluid. It's definitely added into it as well. And really that's where I'm going to pause and stop. I think that's our detailed tour through fluids. Thinking of some of those conditions, so sepsis, we talk about 30 mils per kilo of fluids, really getting that started at an early stage, making your assessment. They're probably going to be intravascularly deplete. Your JVP is not going to be visible. They're going to be cool peripherally, fast heart rate, low blood pressure, high respiratory rate. Be aggressive with fluid, and we will defend your treatment with boluses of intravenous fluid. Burns, there's all the calculations, I'll not go into them too much, but there's a modified Parkland formula that counts pre-hospital fluid administration. So be aggressive with your fluid management in terms of a crystalloid as well, that's available to you. In a DKA protocol, normally that's give a litre of fluid hydration before even starting insulin or potassium or anything else like that. So that can be done in the pre-hospital period, getting that started, that 1 litre of fluid over an hour in the non-shocked people. And if they're shocked, then you're going to be a little bit more aggressive with that. When it comes to kids, whole separate topic we'll do on a separate day. We're thinking about trauma. We've said that, well, yeah, we don't carry blood routinely in our pre-hospital environment, so therefore given an aliquot of crystalloid titrated to a radial pulse. The old days of just hitting trauma patients with fluid, is gone. We've talked about it many times in the past, but we want to maintain enough perfusion to try and get radial pulse, and therefore simulate perfusion to the kidneys and to the brain, and therefore aliquots of fluid titrated to radial pulse. And those are some of the main conditions. So, I'll end it there. If you have any questions, obviously you can ping them over to us on an email and they'll forward up to us, or I'm not sure if Ed or one of the crew will do an online session now. All the best, thank you very much, and good luck.